I am Dr. Shang from the Department of Critical Care Medicine, Union Hospital. COVID-19 is a global crisis now, which was defined as a pandemic by WHO on March 11, 2020. As an ICU doctor, I'm glad to share some opinions and knowledge with you. In ICU, most patients had severe organ function damage. According to recent report, 67% developed ARDS, 29% patients developed acute kidney injury, 23% patients developed cardiac injury, and 29% patients developed liver dysfunction. How should we treat these critical patients? In my opinion, 2 points should be concerned. One is antiviral treatment, the other is supportive care, such as oxygen therapy, respiratory support, proper position, ECMO, CRT, etc. Antiviral treatment should be applied as soon as possible if SARS-CoV-2 RNA is positive. There is no clinical evidence for effective antiviral drugs, including leponavir, ritonavir, based on most recent study published in New England Journal of Medicine. However, convalescent plasma may be a good candidate. I have witnessed dramatic improvement in 3 patients after receiving plasma. The problem is that you need patients who recovered from COVID-19 to donate plasma, and convalescent plasma should be given to each patient several times. Oxygen therapy should be used for patients in hypoxemia. For patients not very severe, you can try nasal cannula, face mask, or high flow nasal cannula at first, but prepare to use mechanical ventilators. Both non-invasive ventilators and invasive ventilators. A short period trial of using non-invasive ventilators seemed plausible. But don't hesitate to switch to invasive ventilator if you think the patient won't benefit from non-invasive ventilation. You may also try proposition, but be prepared that there will be no improvement of oxygen in about 1/3 to half patients before consolidation have developed in the lower back region. If this respiratory supportive treatment fails, VV ECMO should be used as soon as possible. Right ventricular dysfunction caused by ARDS or high driving pressure is also solved by VV ECMO plus super long protective ventilation. During ECMO, proper position should be applied too. Myocardial injury is commonly found in COVID-19 patients. Troponin I level is higher than normal in more than 1/5 of critical ill patients. It may be caused by hypoxemia, SARS-CoV-2 invasion, or even inflammatory response. In addition, myocarditis is not confirmed by pathological finding. Low ejection fraction is temporary according to my observation. Inotropic agents could resolve this problem. ECMO is rarely used. In some patients, refractory shock develops very quickly. Conservative fluoride therapy is a basic principle for ARDS. However, we should not forget the promise of this principle, which is enough tissue and organ perfusion. If you use conservation fluoride therapy, actually, negative fluoride balance is common in this COVID-19 crisis because fever, less fluoride, etc. So these factors together cause pre-renal acute kidney injury. In addition, various particles of SARS-CoV-2 were found in kidney. Hypoxemia and pro-inflammatory cytokines may also attack the kidney. Eventually, intrasonic AKI happens. In a word, it is important to balance the lung and the kidney. If pre-renal AKI happens, fluoride resuscitation should be the first choice. If intrasonic AKI happens, CRRT should be applied. Liver dysfunction developed in about one-third critical ill patients. In our previous study, liver dysfunction was defined as a level of ALT or AST higher than 3 times the upper limit of normal range. All in all, critical ill patients carry a high risk of morbidity and mortality. More attention should be paid to these patients.